I'd like to thank the organizers for giving me the opportunity to present our data here today. I'm humbled and honored to be among the group of folks in this room. We're going to change directions a little bit and focus a little bit more on what I think is a bit of an untapped or unexplored frontier in Impella support, which is the surgical patient who has surgical disease and has to be supported or brought through a difficult high-risk surgical operation. I do have a couple of disclosures there. So there are really a paucity of data in the literature regarding outcomes in surgical patients per se with regards to Impella support. The folks at the University of Maryland did a feasibility study called RECOVER-1 where they used 5 liters of support to help patients get through a post-cardiotomy cardiogenic shock scenario, and they actually had some reasonable results and data from this study. One of the things they did was they looked at the hemodynamics, and what we saw after Impella insertion was an immediate improvement in both the cardiac index as well as the PA diastolic pressure, which is obviously a surrogate for left ventricular unloading. Shortly thereafter, the folks in New Jersey studied an all-comers cardiogenic shock cohort of patients, and although 30-day mortality in this cohort was 25%, of the survivors, the vast majority of them were bridged to recovery, and then there were a small subset that were also bridged to a more definitive treatment strategy. Interestingly, in this data set, about a 64% one-year survival was seen in this incredibly sick cohort of patients. And lastly, we're all fairly familiar with the use of Impella to treat cardiogenic shock, as we've discussed a lot here today, and the impetus for the door-to unloading trial and some of the early results indicate that patients who are unloaded before being revascularized actually do much better and have a significantly improved mortality. In the surgical literature, however, a lot of these data are based on reactionary algorithms that basically react to patients who have cardiogenic shock after the fact. And what we wanted to do is hypothesize that preoperative selection of high-risk patients for the placement of an Impella to hemodynamically optimize them before surgery and also to assist with recovery in the immediate postoperative period would potentially allow for faster recovery, reduced ICU and hospitalization days, improve end organ function, and reduce inotropic needs immediately postoperatively. And we did this in the community setting. So our healthcare system is essentially a community hospital, well, 2 community hospitals within our system. Each hospital has 2 cath labs, and we combined have 4 cardiac ORs. To give you a little bit of an example of the size of our practice, however, although we've got 4 rooms that can do heart surgery, we can only do heart surgery 3 rooms at a time because of staffing. So it is a relatively small program in the community. But it's somewhat remote from other major centers, which is one of the driving factors behind why we want to try to take care of these incredibly sick patients ourselves without making them drive long distances. The cath lab has been putting Impellas in since 2014, and we initiated our surgical program in 2017, where we focused on 3 different categories of patients. The first was the prophylactic patient, where we insert the device preoperatively with anticipation for needing it postoperatively. The second group was the medical optimization group, or the hemodynamic optimization group. Those patients that come in either in shock and have surgical disease, or those patients that come in and need a device to stabilize them because of ongoing acute ischemia. And then the last group is obviously the rescue insertion for post-cardiotomy cardiogenic shock. Our patient selection for those with post-cardiotomy shock consists of 2 or more escalating doses of inotropes, and we define that as greater than low dose. Those patients that we cannot wean from bypass, or those patients that don't improve with an intra-aortic balloon pump. In the prophylactic group, we generally choose patients who have an ejection fraction of less than 20% and require some type of cross-clamping. If we're going to do an off-pump CABG, we would select patients with an ejection fraction of less than 30%, although I must say that we preferentially revascularize our patients on pump at our institution whenever possible. And then if we're going to do multiple interventions, such as valve CABG or double valve procedures, we use an ejection fraction of 25% as our cutoff for placing a device prophylactically. We also use the frailty index and the general surgical gestalt when deciding whether or not to put a device in these patients. And then those patients that are in the pre-op optimization category, they urgently need surgery, so they're not elective, but they have the device placed preoperatively, there are those that have an acute MI with decompensation and who need CABG this admission. Those patients that come in decompensated heart failure with low ejection fractions and need valve operations. And we use this device in that setting to reverse end organ damage, assist with diuresis, and unload the ventricle while they recover from the acute event in preparation for the surgical intervention to ultimately correct their problem. And it's these last two groups of patients that we're focusing our analysis on. So we had a total of 149 patients at our institution undergo Impella implantation during our procedures. 49 of them had some type of surgical involvement, but of that number, 14 were either post-cardiotomy, cardiogenic shock, or had surgical implantation for non-surgical indications. They didn't have surgical disease. So what we decided to do was to analyze the 35 patients who underwent definitive surgical intervention after device placement. There were 12 that were acute or urgent surgical interventions, and then there were 23 who had the device placed electively or prophylactically at the time of surgery, and it's those groups that we're going to discuss further. So the interesting thing in our populations is that for the most part, they're fairly similar. The age is around 60, early 60s. Most of them are male. But what we see in the elective category of patients is that the ejection fraction is significantly lower. We have a mean of 19 with a median of 20, and that is in contradistinction to those patients who undergo urgent implantation of an Impella followed by surgical intervention after stabilization. The reason for that is that in some of those cases, those patients had the Impella device placed for stabilization of ischemia rather than because of cardiogenic shock per se. The majority of the elective cases had a 5-liter device placed. The urgent patients had more often a CP device placed because it was placed in the cath lab. There were a few crossovers in that group where they had a CP device or a 2.5 device placed to stabilize them, and then the 5.0 was placed the next day in order to give them more support until the time of surgery. And you can see the delineation of the surgical procedures that we performed at the bottom there. The Impella duration and the difference was around 5 days for each group. The postoperative duration was a bit longer in the elective group because they had worse hearts at the time of surgery, but the urgent group tended to have the Impella a little bit longer preoperatively, and that's why they ultimately ended up having 5 to 7 days of support total. The ICU lengths of stay, the hospital lengths of stay, both total and postoperatively, were all fairly similar between the two groups. One of the important findings is that in the elective cohort, patients that come into open heart operations with ejection fractions less than 20, only a quarter of them required high-dose inotropes at any time postoperatively, which is what we feel is one of the main benefits of using the Impella device for this indication. None of the patients in the urgent group required high-dose inotropes. Total inotropic days were about 3 for the elective group and 1 for the urgent group. And what we also found was that there was not a significant high rate of end organ dysfunction in the form of either renal failure or liver failure. Unfortunately, those patients that did suffer from those end organ dysfunctions had an excessively high mortality, indicating that those are things that obviously we need to continue to battle and try to prevent, because when they do occur in this critically ill cohort of patients, the outcomes are not very good. Another thing that we noticed in our experience is that we do tend to have a higher utilization of blood products and some additional coagulopathy in patients that are supported mechanically. We don't have a robust enough data set, I think, to draw many conclusions from this, but I think as data sets from larger experiences and multi-center experiences come together, we'll be able to analyze this a little bit better. But it's certainly something that we've noticed and we want to keep in the back of our minds as we move forward. We also noted that there was a significantly higher incidence of hemolysis and thrombocytopenia in the patients in the urgent cohort. And if we look a little bit further at our data, this is most likely because that group of patients had a much higher utilization of the CP device rather than the 5.0 device. And we find that the larger devices have less problems with the hemolysis and the coagulopathy. This is our 90-day Kaplan-Meier survival curve, and what we noted was that there are kind of 2 inflections in our survival. The first is within the first week or two of surgery, and then the second is right about 2 months. And after that 2-month time interval, we have not noted any further mortality in our patient population, so that the mortality, as would be predicted in this cohort of patients, is relatively front-end loaded. And after that, our 2-year survival is above 80%, which is about 20 percentage points better than anything else reported in the literature in similar patient populations. Understanding that what was reported in the literature previously was post-cardiotomy cardiogenic shock type patients. And what we've tried to do is diminish the mortality in this patient population by prophylactically putting the device in. So it seems that this may actually be working as a strategy. So in conclusion, high-risk cardiac surgery with the Impella is safe, feasible, and effective in the community hospital setting. Preoperative identification of high-risk patients who may benefit from unloading with the Impella is possible in the community setting. It does seem that postoperative renal failure and liver failure portend a poor prognosis, and obviously more data is needed, which could permit the development of selection algorithms that may be broadly applicable to multiple groups of patients in practice settings in the high-risk cardiac surgery population. That's actually the impetus for the multi-center study that's being headed by Mark Anderson, Ed Soltis, and Danny Ramsey. Essentially what they're hoping to do is to gather data from multiple sites like ours, pull them together, grab a much more robust data set to hopefully create some more broadly applicable findings within the literature. So I appreciate your attention, and thank you for the opportunity.
Thank you. Quick question. Do you have any sense of how long you have to leave them on to get them in shape for surgery with this prophylactic? What is your time course on that?
It's a good question. In those patients that we put it in and then we wait, most of the time 3 to 4 days seems to be adequate. A lot of times we will look at end organ markers, so creatinine. If they're volume overloaded, we will diurese them to the point where they're no longer requiring oxygen, even 2 liters nasal cannula. If we can get them on room air, not volume overloaded, back to a more normal preoperative weight with more normal end organ parameters on their lab evaluations, that's the day we tend to target taking them to the operating room. But as we've seen, this device can be left in for an extended period of time, so we have a day here or there where we can fiddle if we need to.
And do you keep all of them in through the surgery?
Yes, sir. We'll put them in. A lot of times in the elective cohort, we put them in the morning of the operation. Then we do the operation and support them afterwards. Those that have the device put in for optimization purposes, it will stay in after the operation, and once they have demonstrated they no longer need the support, then we'll take it out.
And do you leave the cannula in the ventricle to pull it out to the ascending aorta, or what do you do perioperatively?
So if we're going to do a CABG and not open the heart, the device will be put into the ventricle. We will cross clamp around the drive line, and it will remain in the heart the entirety of the operation. If we're going to do a valve operation, generally we'll place the wire into the ascending aorta. We'll open, or into the ventricle, depending on what we're doing. We'll tend to open the heart, do the valve operation. If we're going to add a concomitant CABG, we'll do the CABG, and then at the end of the procedure, just before coming off pump, we'll then pass the device into the heart. Obviously, you can't do an AVR with the device in the way, so if it's in the way because it's been there for a few days to optimize them, we'll just pull the device out of the aortotomy. The trickiest is doing a mitral valve operation with this device. Oftentimes, you don't want to have the wire or the device in the ventricle because you don't want your stitches accidentally to catch those things. So in those scenarios, we'll often leave the device out until after the operation's done.
How do you manage anticoagulation in the postoperative period, and do you give protamine with the device in?
That's a great question. So we get them completely dry before we start the heparin infusion through the purge fluid. Generally speaking, we won't start the heparin through the purge until the next day. We want to make sure that, because we've had some coagulopathy issues, we give protamine, FFP, cryoplatelets, whatever we need to do to get them dry so as to prevent bleeding complications. And we have not found any problems with pump thrombosis or anything else with that strategy. Generally 12 to 18 hours after surgery, they're fine to start heparin.
Thanks.
Dr. Williams, that was excellent. Thank you very much.
Thank you.